Welcome back. Finally, we're getting into the clinical study. I had to deal with some technical issues, but we've got them. And what I wanted to do is to be able to have a different format here where I can write and kind of follow along. Uh, so you can follow along with me as we go through the case study. Now, I wanted to try to get the frame of mind, what I was trying to do. We have various parts that I've prepared for you, parts 1 through 5, in terms of the actual uh, skill set. I refer to it, the introductory type of materials, the definitions and terminology. Then I talk about staining, and then the different types of media, then the antibiotics and testing that we do with those, and then the biochemical testing, which is really comes down to like 5 different types of tests. And then all of this information we use to identify the unknowns. Now, in the actual physical lab, uh, it's a little bit more scattered, and some of the students have a little bit harder time following at least the brain wrapping is what I call it, the understanding of what's going on. Uh, but they get the hands-on and the learning of the techniques, which obviously I can't do as well. But I've tried to, during the course, provide the aseptic techniques and various things so that you can actually implement some of these when you get a chance. But understanding what we're doing is really key. So you can refer to these. I have the slides for these on Teams, so you can download the various sections and follow along. But as it applies to the case study, we have a case study not too unfamiliar from the things that you might see if you're going into nursing. Uh, the nursing part of this may be uh, really a little bit early, but that's okay because we're applying now some of the microbiology techniques and skills and philosophies to a case study. And that's why I really like case studies, because it allows us now to see how these things are really used in real world. And so in case studies, one of the first things that I always try to do, I've done many of them when I was a student, is come up with definitions and the terminology so I understand what the wordings and the medical terminologies that may be used. And I usually, I'm an old guy. I used to put them on index cards, and then that way I could do flip cards or whatever I wanted to do to study it. But we have a clinical case study with a 72-year-old female in a nursing home. That's very common. Transferred to a hospital because we're having some issues going on. Fevers, altered mental status, which is not good. So one of the important aspects of any patient in a hospital setting is the patient's number. Usually it's a barcode these days. It's really easy. But the concept behind it is we don't want to mix files. And it's really, really important that we keep these straight. And that's why, they're barcoding. You go in for like a knee surgery, end up having a facial reconstruction or something. That's not good, and it has a lot to do with communication. So those are the some of the tasks that we need to do right off the top. Now there's some underlying clues of what's going on. She has advanced Alzheimer's, bedbound, so you look for bed sores, indwelling Foley catheter because she is bedbound, and as a problem with that is, of course, urinary incontinence, high risk of infection because you have the catheter. The temperature is 101, it's high. She has rapid heart rate, usually inferring some sort of condition. Now, there could be lots of reasons for this, so that is for the physician. I'm looking at this as a microbiologist, and some of the things that she's showing some delirious activity. Abdomen is soft, normal active bowel sounds. So she has, it seems like normal function going on there. She has cloudy urine. That's a huge flag right there. Cloudy urine. We have an ongoing infection. Now this would be put in the category of severe. Cloudy urine is a really, really bad sign of having an infection. Usually, it's probably already ascending nephritis, but I don't know. I look at this as a temporal. This is a timing issue. We need to get some process started from a microbiology standpoint because she has an infection. Uh, so when we do the urinalysis, we see white blood cells. Means elevated white blood cells, you have an infection, so she's dealing with it, but not effectively. And bacteria, of course, are in the urinalysis. The gram stain sediment reveals a gram-positive cocci. Now, I look at that, and this is some of the basic information that you get, and it's all we know at this point in time. Blood and urine cultures grow a gram-positive cocci. Okay, so the patient was tested for the presence of bacteria, clean catch, and we've already had some briefing on clean catch. This is how important this is. If you get surface bacteria or other contaminants, it can really throw off results, especially when we're trying to isolate for treatment. With antibiotics and things, we want as close a representation as possible of what's actually causing the issue. And then typically what we'll do with these types of liquid sampling is that we'll go through and do a serial dilution, and we found that there was about 2 times 10 to the 5th, which in bacteria wise that's not that many, but taking from where it's from, colony forming units per ml. So we take an ml of the sample. We should have about 2 times 10 to the 5th, 2 with 5 zeros, and that's a lot for this type. Now they're whitish colonies, and so that is a clue. A brain heart infusion doesn't tell us anything. It's non-selective. It's not does not really reveal much other than the fact that we can grow it, and reveals that there are whitish colonies. And taking a single count. So this is the baseline information that we had. Now, what I would do typically when you're in a clinical scenario, and it may be an unfamiliar case for you, this is just me. And I used to get cases on the veterinary side. I would do a lot of searching. In my day, I would go to the library and I'd look up things to understand more about the clinical case. I learned more from clinical cases in terms of how they're applied and what we need to do than a lot of times just straight book learning, because these are real world type of scenarios. So obviously she has a urinary tract infection. So this is where we're at. We have a urinary tract infection and it's serious. She's already starting to spike a fever. The urine is cloudy, so my guess is that now we're approaching ascending nephritis. It can get into the kidneys, and she can go into toxic shock and various things like that. So time is of the essence. We don't have time to play around. So what could possibly cause urinary tract infections? Now this was not supplied for you, but it can be easily obtained by doing searches in Google and the like, just to educate yourself on what are the possible urinary tract infections, the causative agent for these things. This is not an exhaustive list, but it's one to kind of get us going. E. coli, which is a gram negative, so that's not really one that we need because they've already identified that it was a gram positive. Proteus species, facultative, it's a gram negative. Now, Enterococcus Callus is a gram positive, so that is one that we can consider. Klebsiella, it's gram negative. No. Staph, saprophyticus, gram positive. That could be. Uh, it's a staph, so it would be grape-like clusters. See under a microscope, so it would have sort of a structure, repeated structure under a microscope of these grape-like structures. So you would see a series of these, and it's not what they see, but I'll show you some additional plates as we go along. And then it could be some other Enterobacteriaceae, but most of those are gram negatives. So really, we only have two that could be under suspect. So this is the key, is at least right away, without any other additional information at all, I just need to know what a presumptive conclusion might be. I'm coming up with at least some possibilities now to track down. Now, I purposely did not include this because if I included this right off the bat, it'd make it too easy. I want you to go and take it upon yourself, and this is part of what this question was all about, is it's okay for clinical studies to do Google searches and things like that to educate yourself. That's what a case study is all about. And so you're going to be assigned a case study for the lab practical, and it's going to be a little bit more laid out than this one, of course. This one was really set up to make you think about all the things that you have to go through in terms of thought processes. And if I just tell you those sorts of things, it goes in one ear and out the other. I've been doing this a while. So those are the possibilities. So how did they get the 2 to the 5th in serial dilutions? All they did was took their initial sample from the urine. You take out 1 ml and you put it in a tube that has 99 mLs. So that would be a 1 to 100 dilution. And so right there, we've diluted it by a factor of 100. And then you take 1 ml and put it into 9 mLs, and that's a 1 to 10. Now, those are typically all there is in terms of doing serial dilutions, and you can choose which the way you want to do with the tube. You could have 99 ml ones and 9 ml ones, and it gives you a sort of a rollout as to what you're going to be looking at. So in this case, they did 1 to 100, 1 to 10, 1 to 10, 1 to 10, 1 to 10, and you go across and you plate them out. You take 1 ml and you put it on a plate, and you go and count the colonies. And so they said here, so there'd be 2, 3, 4, 5, 10 to the minus 5th dilution, which would mean that there's 2 colonies, 2 times 10 to the 5th. I just wanted to try to go over that just briefly on how a microbiologist does that sort of enumeration. So, looking in the clinical study that was provided for you and some of the data that was provided, and we'll go through that now just really quickly. It's sketchy, and a lot of the data is sketchy because a lot of these things are early. They're trying to get these things out as quickly as possible, so we can have something. Now, the doctor already has knowledge that it's a gram positive, most likely causing the problem, and so we have broad spectrum antibiotics. And one of the things that our microbiologists will take very seriously right away is to find out what other antibiotics can we use, because we're in an environment where there's high resistance. In other words, there's a lot of bacteria out there that are already resistant to a lot of different antibiotics. It's a real problem, and I've mentioned that before in class and various things, but here it is being applied in a real world sense. Here's those whitish colonies. This is on a blood auger, and you can kind of see this was after 18 hours incubation, 37 degrees. So you're starting to see that sort of greenish color, and that's usually due to the fact that the bacteria on a blood auger plate are producing sort of a hydrogen peroxide, I guess you could say, H2O2, and it rusts the red blood cells, the iron that's in it, and you get that sort of greenish color. And just to focus on that, here's a lot of times microbiologists will take the same plate set incubate a little bit longer, and just to confirm that yes, it is a type of configuration. It's one of three. It could be beta is bad. These are beta. So you can actually see through the plate, or there's so much the cell lysis, the red blood cell lysis, that you get the clearing. The alpha hemolysis is what we're seeing here. This is alpha confirmed, because if you incubate it longer, it really starts to show the color, but it's not doing this. Okay, it's not clearing the plate. So we know for sure that this is an alpha, which is important, because now this eliminates a lot of things in terms of beta being bad. If it was an organism that did this, then we're looking at some of the really severe types of pathogens. Beta, I always say beta is bad because we have some of the more notorious pathogens that are show the beta hemolysis on the blood agar plate. So this reveals a little bit more about the organism. So, and that's what we're after, to try to help this young lady here with the problem. Now we have some of the microbiology that they did. You can see early on, it really doesn't look too much like cocci to me. These look like blunt rods. But it really depends on the media in which you grow these. And this was grown this is a tellurite agar, and a lot of times the microbiologists will do that as a screening just to confirm the types of organisms. And this is starting to reveal a little bit of information. And then you're looking at the gram stain, and it is definitely a positive. And then the configuration, you can look at this, and you look at the preponderance. It could be technique. It could be they overheated the slide a little bit. Who knows? This is just the first sample that I've seen on that. Now, I'm going to stop here for a second and say that so far the information is a little bit sketchy. Now, the blood agar is clear. You know, we're dealing with an alpha type of hemolysis, and that's pretty clear. And we do have some other data. Sometimes when we're dealing with pathogens and gram positives, some of the microbiologists may be worried that they could be, with a gram positive, could be anaerobes and things like that that could be much more severe. Or we're dealing with, if you go back when we were talking about what the possibilities were for this, saprophyticus, which Staphylococcus saprophyticus would be a beta on the hemolysis, and it would have been clear. But we know, and it's cocci, Enterococcus Callus is a commensa, and known to be urinary, but it can be a blunt rod. It could be that type of form. So we need to look a little bit more, just because it's kind of narrowing down a little bit. Enterococcus Callus, it used to be, in my day, we used to call it Streptococcus faecalis, and they're not doing that anymore. It's a gram positive commensate. It's found in healthy humans, but can cause life-threatening infections like what we're potentially seeing here. So it's a lot of times we see it in teeth, and it kind of tends to harbor this. And in the elderly, we might see more of this, but this one tends to be whitish on a plate. So some of that from a microbiology point of view. So if you do a search on Enterococcus faecalis and start looking at, okay, now how do we nail this? And that's where the common thing I keep saying is the preponderance of the evidence. So that brings me now to the two pieces of information that was given to you at the very end of your package for a case study. This is a standard type of report that a microbiologist in a clinical lab will do. And I went ahead and took the liberty to save time and filled out some of this form. And this is what a microbiologist will handle. This is what you will see in the your patient's file. And so when a lot of times you're briefed, you have a patient's files during, let's say, at the nurse station during a shift, a nurse station shift, you get sorts of reports. Now, a lot of times you're only worried about what is the conclusions. That is what these are for, is some of the microbiology that's been done is for the initial treatment. You might see 2 or 3 different versions of this. A lot of times the preliminaries, now it depends on the hospitals that you work in and understanding the rules of the game. The yellow sheet, if it was colored, it would be the preliminary, and then white sheets usually are more mature type of diagnostics that have run. So you can see that urine types of sourcing, the patient ID number, at least it would be typed in, but it's already somewhat diagnosed as far as the outcome of causing that we see in triage is a urinary tract infection of some kind producing a fever, and those are most likely in the report that you have. The numbers, small blunt rods, it could be cocci. We need to run. So this kind of gives us at least part of the information that we need to roll with. So in your package, you had testing for various sugars. And the reason I wanted to include that is a lot of times you have to run controls when you run samples. And there's a whole wide range of how labs do these things. But usually you have a positive negative control. And so your sample is sort of like the uninoculated, then you know that it's more like a negative test, or if in this case the sample turned yellow or green, it depends on the test, it could be positive or negative for raffinose. So this is a positive test because it produced an acid, and this is negative because it didn't change the color, obviously. And so the actual sample shows that the sample is in negative control on the that's negative test here. So it's the 2 tubes right is negative. So on the right over here is negative, which we knew that. I don't know why it's a plus symbol is negative. And then the left contains reaction. So we know that our sample is negative for raffinose sugar, which sugars are not usually used a lot, but I just wanted to show you that a lot of times we're looking for the production of acid. In this case, the sample is coming out positive for arabinose utilization. And I included in your kit, this wasn't there, but these types of breakdowns that are really useful in terms of trying to follow through in identifying. And so these breakdowns will show you that we know it was a gram positive, and if it's a rod or cocci, and you start going down the branches, and as you see if it's a spore former or non-spore forming, and the opportunities. So knowing some of the basic microbiology in terms of, well, is it a rod or is it a cocci, is really important. And then you start to run into some more detail. The one that we're suspect is not on this particular list, so I went out on the web and I found some that did go into a little bit more detail from sources that were useful for that purpose. And here's Fecalis here, and so it's a gram reactions positive, bacillus or cocci. We're not really sure, but we see at least in the clinical slides that we saw, it's a blunt rod of some kind. So here it is there. So we kind of go down this side here, and then we run the urea test. Now, in your packet, you didn't get the urea test, so we need to to get more of that information to actually conclude what we wanted to address in the original questions. Now, this is aside from the clinical part. We have enough information and suspect that we can go after the fecalis, and then subsequent data will just either confirm or deny, so we can shift the treatment if the data tells us to do so. You can kind of see now how that works. But on this, the diagnosis would require some additional information to prove in a court of law. That's the way I kind of like to look at it. And so we ordered some different that you don't have in your kit, and I will provide this for you as subsequent information. And in doing so, and we want to make a case that it is this particular organism, then you can go out on the web and get more of a definitive series of tests that might be run. And I found one that kind of goes through all the characteristics of Enterococcus faecalis, and we can see there's raffinose. It's negative. We saw that. Positive for some of the other sugars. So we would want to run some tests, like a positive test for nitrate, and we can run a test for nitrate, and we find that the organism is positive for nitrate. It runs with the controls, and you can see. What else? We can run tests looking at urease, and it should be urease test should be negative, and we got the data, and in fact the data does come back negative, and so that's in your kit, and that helps confirm that. You can see where we're going. Citrate is negative, and so we can use either mannitol saltsager, well, that's for mannitol, is positive. Mannitol, so it turns out to be positive for mannitol. So we've now nailed another preponderance of the evidence, and you're looking at use of, let's see, have a McConkey auger, and we want to see a fermentation of lactose, and we look for lactose in the listing here. If we have lactose is positive, and this organism is positive for lactose, and so based on all of that information, we can go back to our chart, and we can see that we're pretty well convinced ourselves that the organism is the Enterococcus faecalis, and that's what you would do, and you would come up with a more detailed list. The initial list, if you notice, there was an antibiotic listed, and the screening, the typical type of screening, if you look at your you have the test that we run with the disc that's been soaked in a particular antibiotic. You notice all of these are resistant to the antibiotics, to the point where it just kind of goes through a screening. We're not even interested in knowing the names of it. We do have one after you do some analysis. It is sensitive. It turns out to be linezolid, the antibiotic, and we included that here. And so with the measurements and the like, you would even know how much to give of that antibiotic twice a day or whatever, a certain amount. So the treatment can be started. Now, they may have used a broad spectrum gram-positive type of antibiotic, but can switch now that we know that it is sensitive to this particular antibiotic. It'll make the treatment more effective. That is a standard type of case study that really takes us through all of the things that we've been trying to learn in the latter part of this semester and applying it for a case study. So the final conclusions, then you can fill out on that sheet that I provided with the kit is the naming of the organism based on some of the subsequent data that I was able to order and to obtain, and we're able now to fill in that information. And of course, I can't seem to get my hands on it right at the moment, but you get the idea of why we run these tests for that purpose, is to identify. So on the it would be Fecalis. Determine the presence greater than. We had 2 times 10 to the 5th colony forming units, and we can use as we determine with that antibiotic, and we've placed it on the report. But for here, the antibiotic, and that's it. And I've already seen some reports with this, but the really key learning for this is that they did have to do really quick sort of analysis, because we were dealing with a stat situation, and so we have to kind of go out on our own. It's not so structured. This is where the fun comes in. As a clinical microbiologist, we educate ourselves to look for the clues. Now, one of my favorite sayings from Louis Pasteur is, chance favors the prepared mind. So our job is to prepare our mind so we can find the clues that we need to convict in court, saying that, well, okay, this is in fact Enterococcus Callus, and we're on our way to helping this very nice young lady here. So I hope that helps in terms of clinical study. You're going to be getting one for the lab practical. It'll be a lot more straightforward. I will provide you with the charts and data that you need. But your task is to interpret the results and to identify the right organism based on those results. And pretty straightforward. But again, it'll be another case study where you'll have some underlying condition, and then you'll be free. It's separate from the online exam of 40 questions or so that you'll take. But this allows you, it's a standalone. You can write it up and then submit it, email it to me, and as part of the grade for your lab practical. I hope you see now the value of using case studies and tying all of the stuff that we've been talking about throughout this particular semester, and then elements of these will be used in addition to the aseptic technique on the question part of 40 questions that you'll get for the other portion of the lab practical. I hope that helps, and I will be sending out that information as soon as I can, and I appreciate your time and patience.